Welcome to the Toward a Healthy Built Environment Training for Health Professionals series. We're excited to be introducing Lianne Carley, a policy strategist with the Population Health team. Her presentation is entitled Health Equity and the Built Environment.
So, when you think about the built environment and how the built environment work, essentially what it uses is a health lens to ask if a given action is going to promote and improve health for the general population, which is great. That's a great thing to do, but unfortunately, not everyone experiences the same benefits from the same policies, actions, and initiatives. So, for an equity approach, we'd like you to apply a lens on top of that to ask if there are some groups that are benefiting more than others from a given action. And this might be a good thing because it might narrow health inequities. It might be a bad thing because it might widen health inequities. So what are health inequities? Well, they are the differences in health status that are seen as unfair and avoidable, and they're often because of systemic barriers that are external to the control of individuals. So what does that look like? Well, income is one that is often used to highlight where inequities in health are occurring. So this one shows basically the difference in self-reported health status between low-income groups and high-income groups, with the lower-income groups reporting higher levels of poor and fair health than those of the higher-income groups. And you can see it's a gradient there. So the lower your income, the higher your rate of poor or fair health. This one shows, and I'm not going to get into detail of this one, but it hones in on specific disease groups, so heart disease and diabetes. And again, you can see the same grading occurring where the lower income groups are experiencing higher prevalence rates than the higher income groups. This graph shows that inequity even higher. So basically, you're looking here at 50-year-old men over a period of time. And you can see with that poorer income group that their life expectancy has essentially stayed the same. In fact, it's gotten a little bit worse over time. And even more to the point is the inequity gap between the higher income groups and the lower income groups has increased over time. So in your healthy built environment work and in our population health work, we want to try to make sure that any given action does not increase that gap. And preferably we are narrowing that gap with our actions. So aside from socioeconomic groups, who else is vulnerable to health inequities? It depends. So it's not set in stone, and it's going to depend on the context. But usually you look for it along socio-demographic lines. So differences between age groups, gender identity, sexual orientation, ethnicity, race, immigration status, place of residence. That could be rural, urban, it could be homeless versus housed, disabilities, and so on. But one of the points here is that you can't use an equality approach and expect that you're going to improve the health of the whole population. And the reason for that is here. So that's an equality approach. You're using the same approach and you're expecting the same outcomes. But you can see that little tyke in the purple shirt there? He's not having the same experience as the other two. So an equity approach is taking those barriers into account because what's happening to him is not his fault and it could be avoided. So an equity approach takes those barriers into consideration and you get equal outcomes. The thing that we have to keep in mind though is reality. So in reality there are great inequalities. We usually have to put in quite a bit of extra effort to make sure that there are going to be equal outcomes. The point is that using a one-size-fits-all approach is not going to achieve population health. So what does that look like in the built environment? So instead of looking at the big picture, I'm going to hone into a microenvironment, and it's going to show you some concrete examples of some equity actions that have been used to address access, social inclusion, and other barriers to address equitable outcomes for a variety of population groups. So we're going to hone in on the toilet, and specifically to the public toilet. So here's a typical situation. You've got a design of a public toilet. You've got a men's and a women's. It's the same layout. It's the same allocation of space. The outcome, and every woman in this room knows what I'm talking about, is the same all over the world. The outcome is different. And so basically, you have the same approach, but different population groups are experiencing different outcomes, and it's unfair, it can be avoided, and it's inequitable. So one of the policy actions to address this came about in Hong Kong in December, where the development minister announced that they were going to have new regulation for all new developments in the public realm. It's now 1.6 female toilets for every 1 male toilet. Previously, it was 1 to 1. Now, women take longer in the bathroom for a whole host of reasons, biological and otherwise, but sometimes it's because we have young children, which led to this design aspect. And that's not a standard, change tables in every toilet, but it does greatly facilitate access to women with young children. Where inequities are kind of popping up is that it's not always in the male bathroom. And that actually can result in a burden on women for always having to do the changing of the diapers. But also when you think about men who are out by themselves with their kids, that creates a real barrier for them. And as well for lone male parents. And that's a population group whose number is increasing. Disabilities, I mean, that's a pretty obvious one, but can you imagine what that would be like if you had a physical disability and you couldn't access the toilet in the public realm? This is a population group that experiences higher levels of social isolation, so we want to make sure that there are no barriers to them getting out and engaging in community. An increasing issue that's being identified is for the transgender population, and for people like dyke lesbians who have very negative experiences when they try to access a public toilet. So one thing that can be easily done is ensuring that there's a single toilet that anybody can access, and that actually helps to create access for everyone. So those are just some examples within the public realm of inequities in access for a variety of population groups when the resource exists. When it doesn't exist, that's another thing that layers on top of it, and it impacts different population groups differently. So, in terms of families who have children or pregnant women, that definitely has a negative impact on them when there are no public toilets, as well as older adults. So when we think about older adults, they are also a population group that suffers from social isolation, and so we want to make sure that there are no barriers for them getting out and about for their health and wellness. In fact, when they are taken out of the public realm, you can't really see this maybe from where you're sitting. There are a majority of seniors in this protest group because of these toilets that have been taken out of the commission. The other people are people with chronic diseases like Crohn's and colitis, IBS, and diabetes. They also suffer inequitably when there are no public toilets. And so here was a campaign that was done by Crohn's and colitis last year. It's called Go Here, and it was about facilitating access to toilets in restaurants and in office buildings for the general public. So there was a promotional campaign, an app, posters, and decals. And when you think about it, it's not just because they too actually suffer from social isolation, but they need the toilets to maintain their chronic condition and to manage their health and wellness. And then finally, my last example for the toilets is people who are homeless or they're staying in shelters. They have to get out during the day. And they not only have problems accessing toilets, they're not going to go into a Starbucks or into a business establishment like the rest of us. So there are various actions that have been taken, and it's an issue that comes up all the time in the downtown east side of Vancouver. One was by the Portland Hotel Society, where they had these thunder boxes available from midnight to 6 a.m., and then the city of Vancouver put in some of these toilets. But these are just some examples, honing into one aspect of the bill realm where there are inequities that can be addressed with policy actions. So the point is that different groups experience the built environment differently, and that some people are suffering unnecessarily barriers to access to things that they need for their health and wellness, and that these things can be removed through policies that affect design and resource allocation. So this is a real opportunity that we're basically saying apply an equity approach to your healthy built environment work, and that means that when you're on an active transportation working group or you're reviewing an OCP, that you're doing it with the lens of, are there different people that are experiencing barriers in the environment that are negatively impacting their health and wellness? And your role essentially is around creating awareness of those inequities and also advocating with and on behalf of vulnerable population groups so that there's a more equitable built environment. So how do you know where they're occurring? Well, how do you find out? You become more aware of your community, and you can do that just through observing. You know, often we're looking at the ground or we're walking through the towns, but just being aware and talking to people, networking, being in the know. And also collecting and analyzing data. So maybe that's stuff that you collect yourself, or maybe it's analyzing other people's data sets and studies. In the case of Hong Kong, they did a combination of both, which you would probably do as well. So in the case of Hong Kong, they heard about the issue with the females in the toilets, and then they did an observational study to get a better understanding of what was going on and what needed to happen to address it. In the case of Montreal, they did some work on playground safety. And they basically did a combination of the above as well. They looked at local data and they combined that with observation. And this links into the community design component of the healthy built environment. So I'm going to tell you a little bit about one that was highlighted in this document here, which is interventions that contributed to reducing health inequities. And again, it looked at playground safety in Montreal, and they looked at the high-level data first. So basically what that said was that 29,000 or more children each year in Canada receive hospital treatments for injuries that occurred in playgrounds. And then they looked at, there's an inequity here. Children from low-income households have higher rates of injuries requiring hospitalization. And then from a public health perspective, we know that studies show that child development impacts health in childhood and in adulthood. So this is a key opportunity for health promotion and prevention. And we can level the playing field. We can actually prevent health inequities by ensuring that all children have equitable access to the things that they need to thrive. So they combine that with local level data. They did a study that revealed that twice, what does it say? They're twice as common in low-income neighborhoods. I guess I could look here. That play areas were unsafe, twice as common in low-income neighborhoods. And then the actions that they took were that they raised awareness of the issue with playground managers, and they advocated for and worked with those playground managers to basically apply the Canadian standards for safe play areas. And the result was that over a 5-year period, there was a 13% reduction in injuries in playgrounds, and that the level of safety in low-income and high-income neighborhoods almost came up to be the same. And it's probably the case that that never would have occurred had there not been an intentional effort to close that gap. So the point is that actually the built environment can reduce health inequities, and we were just talking about playgrounds there. There are other studies that show that large-scale initiatives that targeted the built environment of disadvantaged neighborhoods improved the health of the residents living there. And there are projects all over the world, the specific ones in Norway and England, they positively impacted the physical health as well as the social environments and the mental health of residents in disadvantaged neighborhoods by basically affecting traffic patterns and lighting and landscape and parks and the recreational facilities. So there's an important opportunity here for you as environmental health officers working in the built environment to reduce and prevent health inequities. And you can do that by, when you're reviewing those CPs, applying an equity lens, working in active transportation or neighborhood designs, recreation plans, and basically anything in those 5 areas that are outlined in that healthy built environment document. So where do you start? And then this is my second to last slide, is where you start. So where you start is this presentation for one, but getting a better understanding of what is health equity. And for this, Google is your best friend, but Google could also be your worst enemy. So you could look at this document, which we did, LVCH, which is Tackling Health Inequities, on our website. Chances are your own health authority has also done something similar. YouTube is also your best friend. You can learn about health equity in 3 minutes or even 2 hours. We've also done a video at Integral to Health called Population Health, a New Agenda, which is on YouTube and on Vimeo. And we also did one recently around healthy public policy, which looks again at an introduction to health equity and then dives a little bit into areas of the built realm. Which brings us to our seventh step, which is learning more specifically about health equity in the health built environment. So one of the documents that can help you with this is done by Healthy Canada by Design. This is community design and health equity, and it gives you some basics around that. You can also look at these things, which are the policy primers on the Vancouver Global Health website that dive into areas like housing, social cohesion, quick introduction to the link to health, health inequities, and then some policy examples on the flip side. And then finally, viewing your communities from the equity lens to get an understanding of where health inequities are occurring. This starts with a good dose of empathy. You have to be able to understand how somebody else is experiencing the built realm from their frame of reference. That's key to equity work. Observing, like we said before, talking to people, networking, and asking questions. And the kinds of questions that you want to ask can be found in equity lenses. So it's essentially just a series of questions that you would want to ask to uncover where equity or inequities are occurring. And one document that can do that, which you can't fully read, is called Health Equity Tools. And it's a big document that has lots of examples of different kinds of equity tools. Another one is this one, which is maybe a little bit more in depth than you would want, but it's the development of priority health equity indicators. You wouldn't really use it in great depth, but it gives you a good overview of equity dimensions, health issues, and the intersection of the two. Understanding where pressing health issues are in your community, and if there are some groups that are suffering more than others. And then looking at data, like the My Health, My Community data, and looking for inequalities in where health issues are happening, and also in the social determinants of health, which are the risk factors of the risk factors. So my final slide, learn the basics, great. And so this is basically about reviewing what your role would be as environmental health officers in equity work in the health environment, and giving you just a few more examples. So you do this by raising awareness, you're starting the conversation, that's the key. And you're presenting data, if you have it, and you're basically keeping equity on the agenda. And then you're identifying where inequity may be occurring, and that's when you use those equity lenses. And then it's about identifying and working with partners to address those inequities through better policy and design in the built environment. And what we would do specifically on that will depend on the context. So just a couple of examples of this. One of those policy primers. So this one is around social cohesion, again on the VStage website. And it gives some examples like this. As an environmental health officer, you would be promoting the idea of doing access audit. So it would be assessing whatever it is, a building, a park, in terms of access barriers, and that would be language, signage, affordability, hours of operation, physical access, sense of welcoming, all around how is this going to create better access for vulnerable population groups. Another one is the Healthy Built Environment Toolkit. It has a lot of concrete examples and advice, specifically in the housing one in the area. So for example, it would be around you promoting the idea of increasing access to affordable housing and through the provision of diverse housing forms. And basically priority housing for vulnerable population groups, like people who might be homeless, the elderly, aging groups, and people with disabilities. Second to last example here, this one is looking from a public health perspective at parks and recreation. So what these guys did was they looked at the disparities in the distribution of access to public parks and recreation facilities, and the disparity in the condition of those, and then the link to physical health and wellness. And then the last one here is there's a bunch of public health professionals who worked with Aboriginal groups, and they look at death data, specifically deaths that were occurring due to injuries, and then they work together to come up with local strategies. This is linking into the big picture. So the big picture is we want to reduce the health inequities between Aboriginal groups and non-Aboriginal groups because there's a huge disparity in outcomes. And then you can do that by also improving health at the local level local level. All right, so hopefully this is how I'm going to leave you, which is like excited to do this equity work, your healthy built environment, and not so much like this guy. But either way, I recommend that you tap into your population health team and your health authority, also known sometimes as a health equity team, and or into your medical health officers, because we should be able to help you to take that next step in order to integrate health equity into your healthy built environment. Thank you.